My talk is on interventional treatment of acute coronary syndromes. And I would like to start by taking you back in history about 25 years back in time. This slide dates from 2001, and this was really the pioneering phase of primary angioplasty. And as you can see, this was a patient coming in with acute inferior STEMI with clear ST elevations, an occluded dominant circumflex artery, and this is what we term optimal scenario because symptom onset was within 2 hours, door to balloon time was less than 1 hour, so the patient came very quickly to the hospital. The vessel could be promptly recanalized with angioplasty, rapid, complete ST resolution. As you can see on the right-hand panel, the EKG normalized completely with no Q waves, so no sign of transmural infarction, and normal left ventricular function at discharge. And please note that this was the pioneer phase of primary PCI, done with balloon angioplasty plus minus bare metal stents at that time. So that was the beginning. How did it evolve? About 10, 15 years later, this was the new standard of doing primary PCI. The vascular access shifted to radial access, leading to a much lower event rate, complication rate, bleeding rate, and even mortality in some studies. In the case of thrombotic occlusion, recanalization was done without routine thrombus aspiration. So in this case, we didn't do a thrombus aspiration, and at that time, drug-eluting stents became the standard already, and we had a nice result with no signs of relevant distal embolization. So now, after many years, we still have some critical areas in STEMI treatment to discuss. And this is how to shorten time delays to reperfusion, because time is muscle, as we know, in acute coronary syndromes. To perform comprehensive primary PCI delivery, also in countries with widespread geography. How to optimize pre and peri-procedural antithrombotic therapy, how to deal with large thrombus and no reflow, a rare event, but catastrophic sometimes if it happens, dual antiplatelet therapy duration after primary PCI, and more recently, the issue of complete revascularization in multivessel disease. So although successful, primary PCI is widely achieved. There are still many open issues. Now let's look at the latest guidelines that we have from the ESC, published in 2023. And as you can see, these were the first ACS guidelines covering the whole spectrum from unstable angina, NSTEMI to STEMI. And we have different chapters listed here on the left. And pertinent to my talk is the invasive management, where we should go as quickly as possible in the case of STEMI. And we have to be more selective, as we will see, in NSTEMI. And revascularization here is the key issue, to be quick and safe. And complete revascularization, as I said, is the most recent issue and topic for scientific trials. But most importantly, we have to think ACS, which means that we really have to secure the diagnosis, and that still comes first. To look at the patient, whether he or she has typical or atypical symptoms, whether the ECG is abnormal or not, and whether biomarkers and other parameters fit for the final diagnosis. So the first challenge we have to decide on interventional treatment is reaching time to treatment within the given time frame, less than 2 hours from diagnosis. And this is taken from the guidelines, a part of this algorithm showing that if the patient comes to a PCI-capable center, the aim is to have wire crossing within 1 hour of diagnosis. If the patient is picked up by the ambulance or by the EMS and has to be transferred, wire crossing should be achieved within 90 minutes. So also quite ambitious. And if this is not possible, then lytic therapy is still the option to go. And then the aim is to administer a bolus within 10 minutes of the decision making. So to limit the time delays shown on the right-hand side, we should avoid patient self-presentation. So the patient should always call the ambulance, the EMS, optimize first call for help through community education, and avoid emergency medical system and other hidden system delays. And it's very easy to overlook these hidden delays. So let's now turn from STEMI to NSTEMI. Here, it's more important to be selective and to have a close look at the individual patient and to risk stratify. This is the central figure for NSTEMI in the latest guidelines. Let's look at the details. We have risk categories: very high risk, and non-high risk. And our approach to invasive strategy depends on this risk stratification. So very high risk in these latest guidelines is defined as the unstable patient, either symptomatically, hemodynamically, or with dangerous arrhythmias. In this case, the patient has to be taken immediately to the cath lab. In case of high risk, this means confirmed diagnosis of NSTEMI with ECG, biomarkers, troponin, and or transient STT changes, ongoing ischemia. In this case, the guidelines say that the patient should be considered for invasive strategy within 24 hours, so early invasive. And it's clear that inpatient invasive strategy is the treatment of choice. Non-high-risk patients do not fulfill either very high-risk or high-risk criteria. In that case, we can be even more selective and look for maybe alternative diagnoses, look at the risk of the patient altogether. Maybe it's an elderly comorbid patient, maybe it's a type 2 infarction. So this is a more selective approach where inpatient invasive strategy should be considered after confirming diagnosis. So the bottom line here is that patients with NSTEMI are often older, with comorbidities, and therefore an individualized treatment strategy based on risk stratification is still the way to go. Now, a brief look at antithrombotic therapy. You see a big central figure here addressing the whole spectrum of anticoagulation and antiplatelet therapy. Let's go quickly to this part of this figure. And I just want to draw your attention to routine antiplatelet pretreatment. There we had a quite important change in the recommendation, namely pretreatment with a potent P2Y12 inhibitor in the case of STEMI, which has been downgraded to a 2B recommendation. So it may be considered because the evidence was reviewed by the task force, and it was found that the evidence is not very strong, that with short delays to the cath lab, so I have to mention short delays, the benefit of pretreating with P2Y12 is not really very consistent. So you may do it, but it's not mandatory. It's not a class 2A or 1. What about long-term default strategy of DAPT after ACS? Here, the default strategy is still that in all patients, a P2Y12 receptor inhibitor is recommended for 12 months, unless there is high bleeding risk. So in any patient, you should consider 12 months of DAPT. This is still heavily debated, And many trials are still ongoing to prove that we can shorten depth. And this is the part of the guidelines showing alternative strategies to reduce bleeding risk. Because we know these potent agents in patients that get older and older in our hospitals and cath labs, we have to consider high bleeding risk. And what do the guidelines state in this case? For abbreviated DAPT strategies, there is already a quite strong recommendation, class 2A, for abbreviating either to 6 months or even 3 months. And the evidence is increasing that this is beneficial to a majority of patients without paying a price to increase in ischemic complications. Regarding DAPT de-escalation strategies, this means de-escalating from a potent P2Y12 inhibitor, prasugrel or ticagrelor, to the less potent clopidogrel. And this can be done, but not before 4 weeks after ACS in case of high bleeding risk. So what about revascularization for ACS? Here we have two main strategies. The culprit-only revascularization, so just open up the infarct-related artery, or complete revascularization. And we have more and more evidence that the second one is the one that benefits the patient. Regarding complete revascularization, we have the choice between immediate in the index sitting or staged complete revascularization. And here we can do it either during the index hospitalization or within 45 days of the acute event at a second hospitalization. So culprit only or complete. This question has been addressed over the course of the last 10 to 15 years in multiple randomized trials shown on this slide. And as you can see, all of these 4 trials have widely separating curves. So all are significant in favor of complete revascularization. The bottom line here is that non-culprit lesion revascularization performed either immediately at index PCI sitting or staged during index hospitalization was better. But there was a significant reduction of primary endpoints driven by refractory angina and repeat revascularization, so the softer components of the combined endpoint, and these studies were really not powered for mortality. The more definitive answer came from the very large complete trial published a few years later, enrolling more than 4,000 patients from 140 centers in 31 countries, so a truly global study, clearly showing that with the 2 endpoints, complete revascularization was superior. So this was a superiority study to culprit lesion only PCI in reducing the risk of cardiovascular death or myocardial infarction, as well as the risk of cardiovascular death, MI, or ischemia-driven revascularization. So altogether, this led to this recommendation in the 2023 guidelines. In case of multivessel disease and hemodynamically stable STEMI patients undergoing primary PCI, complete revascularization is recommended either during the index PCI procedure or within 45 days. We don't know yet the ideal time point between immediate and 45 days, but that's a clear-cut 1A recommendation. So what about the role of intravascular imaging? We know that intravascular imaging is beneficial to the PCI result in general. Regarding the role of imaging in ACS, evidence comes from, for guidance with IVUS in ACS is derived from subgroup analyses of all-comer trials. And a meta-analysis of available randomized trials confirms the superiority of IVUS guidance in the reduction of MACE, although a definitive large-scale multinational trial is still missing. However, you see that in the latest guidelines, this is the central figure. When you have a clear culprit lesion suitable for PCI, intravascular imaging should be considered on the left-hand side to guide PCI to achieve an optimal PCI result. In the case of no clear culprit lesion, on the right-hand side, intravascular imaging, preferably with OCT in patients with ambiguous culprit lesions, may be considered. So 2B. Now I come to the end. Evolving concepts in acute coronary syndromes. There is this interesting notion of plaque rupture versus erosion. And sometimes you have an ambiguous angiographic picture of the culprit lesion. And in this case, intravascular imaging, again, with OCT may be very helpful in distinguishing between plaque rupture or plaque erosion. And this may be relevant for the treatment of this given patient. Secondly, the role of inflammation and its inhibition is a very hot topic. And giving the somewhat contradictory result between the earlier Colcott trial with colchicine and the negative results for colchicine and ACS in a larger randomized clear synergy trial, it's still open whether we should selectively address inflammation in the setting of ACS. Premature MI in younger patients and its mechanisms is also an emerging field of research. Alternative non-occlusive mechanisms, very interesting, of AMI, MINOCA, MI with non-obstructive coronary arteries, drug-induced spasm becoming more and more prevalent, and spontaneous dissection. So this is seen in women, in younger patients, and we know that we see more and more younger patients also with STEMI. And of course, new targets for secondary prevention is an emerging, very interesting field. So in summary, what are the remaining challenges in treating patients with ACS? Timely reperfusion therapy is still the primary goal, and we know that in clinical practice, this is still not met in many cases, and this affects the long-term prognosis of the patient. Risk stratification in increasingly complex and comorbid patients is a clinical reality. We have to take care of these. We have to be a bit more selective in treating these patients, not go too fast to the cath lab unless you are very sure about the diagnosis. Optimal management of cardiogenic shock and the role of mechanical circulatory support. We will hear about this in a moment. Microvascular obstruction, I haven't talked about this, is still a relevant thing because you don't really see it nicely on the angiogram, but then later on you will see that you will have a suboptimal reperfusion result, and this is an unresolved issue, whether it should be addressed pharmacologically or otherwise. High ischemic versus bleeding risk when choosing antiplatelet post-ACS therapy and its duration still open. And secondary prevention, of course, this is key because we know that the effective establishment and adherence is still a problem. Risk factors are not really controlled. Beta blockers in preserved LV function, you will hear about this tomorrow at the Best of ESC meeting session. SGLT2 inhibitors in patients without diabetes, a very interesting new area. And the role of lipoprotein A as a treatment target is also studied in ongoing trials in phase 3, and we will know the results of these trials in about 1 or 2 years, and this is a big hope. So with this, I conclude, and thank you for your attention.